Hi, welcome to Detours, Understanding Acquired Brain Injury. Today we're going to be shifting gears a little bit. We're going to talk about focus of neuropsychiatry and about mental and cognitive disorders and their origin. So we're going to be talking about like sequelae, the signs and symptoms that appear quite often in traumatic brain injury patients after they've gone through rehab and after they've come home, things that can become problematic for them later and throughout life in many cases. So we'll be looking at things like, well, today, aggression and how it's treated. Many times now, there are, of course, justifiable reasons for someone to be a bit aggressive. And we're not talking necessarily about fighting or, that kind of thing, although it can apply. But we're also talking about verbal aggression, spitting, biting, and being excessively argumentative, cursing, and for many times just a small thing that's bothering a person with traumatic brain injury. And we'll be looking at treatments and ways that aggression may be handled. We'll also be looking at systems that may not be functioning properly in the brain and talking about where it originates from. So that'll be what we'll be focusing on today, and we'll be getting to that in a moment. We'll also be looking at post-traumatic depression, post-traumatic psychosis, associated hallucinations. That will be a later episode. We'll be looking at things like post-traumatic hypersexuality. This can occur also, or hyposexuality. Unfortunately, not a lot of research into these areas because of the way this country feels about sex and discussing sex. So not much about that. Also discussing things in the future like post-traumatic insomnia and other topics dealing with psychiatry and how damage to the brain can impact various disorders. Unfortunately, many patients who have traumatic brain injury have their brain injury discovered in the psychiatrist's office instead of at a rehabilitation clinic or when they're first waking up. And many never even end up in the rehab. They have a small bicycle accident or they hit their heads or they fall off the risers, if they're singing chorus in school or, they hit their head on a dryer door or something like just a bit too hard and just kind of disoriented for a little bit. And they figure, well, that's fine. And then find out that a new onset of behavioral symptoms, something upsetting. And the psychiatrist will perform a psych exam and find out, there's something not right here. And then they may order them for further neuropsychological testing and find out that this person's actually suffered traumatic brain injury. In fact, most traumatic brain injuries would be classified as mild. We discussed that on another video in classification system under disorders of consciousness, and we can go check that out. But we want to move on here right now. So we will be discussing aggression and be talking about its treatments and causes, because it can be quite complicated, and I'd like to address a lot of different things about post-traumatic aggression. First of all, it's important to note that post-traumatic aggression and hostility as well derive from a variety of different sources, and not just the traumatic brain injury itself, but one can also see post-traumatic aggression from things like pain. If the patient's in pain, they may act out because they cannot communicate, or because they're having cognitive problems, or because medications may precipitate aggression. What's interesting is quite a few of the medications that we use under some circumstances to help reduce aggression may actually make it worse or cause it because of misinterpreted signal. Also, some aggression is because we're rewarding the wrong behavior. Classic Skinner, those of you who remember from college or high school psychology, if you reward aggressive behavior, you're going to get more of it. And I'll talk about that in a moment. So let's start talking about aggression. One of the first things that's important to do is separate out aggression from other things that may look like it to the layperson but aren't. For example, there is agitation. Agitation is not as directed as is aggression. Agitation is restlessness. Patient may be moving around a lot. They're purposeless, non-directed activity. So they'll be maybe pulling an endotracheal tube, nasal tube. They may be pulling at IV lines. If they're in the ICU, they may be pulling at clothing. They may be pulling at what somebody else has on them, jewelry or other things like that. As patients are coming out of a deeper state of unconsciousness, or as they're trying to figure out the world around them, or if they're uncomfortable, something is rubbing or is making them not feel good, they may become agitated. And there are different treatments for this. Most commonly just take away the thing that's irritating them or that's causing the agitation. If you can't, there are sedatives which can be given, but really this is not the preferred way, really, unless it is general psychomotor agitation. The best way to deal with this is to see if it can be reduced. If stimuli is too much light, too much sound is coming in to bother the patient, try to cut that down. If somebody is there for too long, if they're talking, rubbing, touching a patient, they'll be restless. It may lead to spontaneous autonomic activity, watering eyes, quicker breathing, quicker pulse. Again, mentioned this in the video about disorders of consciousness, autonomic reactivity that you'll see. And these patients are not feeling well because of the agitation. It can cause serious disruption of their vital signs. And so really we want to try to keep the patient, as they're moving through the stages of deeper levels of consciousness, we want to keep them comfortable. And again, there are different medications, but the goal is to reduce excessive stimulation and make sure they're comfortable. So this is agitation. But the important thing to remember is it is not directed at anyone or anything in the environment. It's just non-focused. So that is agitation versus aggression. Now, also, there's disinhibition. This you see commonly, especially with frontal lobe injuries, where there is the lack of social control that the patient has. They'll act out, not necessarily aggressively, but more in a verbal way, or they will not adhere to social norms, whether it's physically not sticking with the rules, or sexually, or in a kind of like they'll do whatever happens to be on their mind. And this disinhibition can be very non-physical. And this is very typical, what you'll see, and commonly misinterpretation of other cues in the environment, and they'll respond to things they don't understand, and it can lead to a lot of trouble. I will be talking about disinhibition in another episode, but it's, again, not a directed physical acting out necessarily. It's related, but it isn't the same thing. But it can be a problem, and treatment is similar, and it tends to be more prominent early on. But there are some patients who have permanent problems with disinhibition, with lacking the ability to stop acting out, or to lacking the ability to control their own behavior in this fashion. And so those patients routinely put themselves in danger, emotionally, socially, and often end up quite isolated. This is potentially a very difficult problem. And so it needs assistance from both cognitive therapists as well as psychologists. But in some cases, it's really never quite completely resolved. Okay, let's move on now. Okay, so what is aggression by definition? Clinically, what we mean is either a verbal outburst or physical violence directed towards a person or an object. And it can be either instrumental. What we mean by that is it's directed towards a goal, or it can be disorganized, just punch someone or throw something just because you're dissatisfied. And if there's really no thought behind it, it can be an organic syndrome. It can be just throwing stuff, kicking, not really no thought at all behind the acting out. And these are treated differently. The instrumental kind, where it seems to have a goal to it, but where it's still harming the treatment, quite often in the early stages of traumatic brain injury, it's more the organic syndrome kind of thing, and there isn't much cognition or planning behind it. These are more often treated with medication, whereas if it's due to reinforcement that was accidentally given for behaviors, and the patient feels, hey, I can get extra attention, or I can get rid of somebody who's making me work. I don't feel like it today, or whatever it may be. I don't like that therapist. They actually make me do my exercises, or maybe if I throw a bunch of stuff on the floor, I can disrupt it enough. Oftentimes there isn't quite that amount of planning, because those systems in the brain that are associated with excessive aggression and this kind of anger and hostility, usually those are the very systems disrupted, so you don't get that till later. However, these are more often treated with behavioral and cognitive methods of psychology. So they obviously would require different approaches, but the earlier, more organic or outright aggressive need to be treated pharmacologically. And so we'll be looking at that too. So when we're looking at the basis for a lot of this, different areas of the brain are involved, especially with moderate to severe traumatic brain injury. And the regions typically involved, well, you can get my brain here, are the left orbitofrontal areas. So if you look dead on here at the brain, this is the left frontal, kind of flipped here, but underneath here is the orbitofrontal region. This area is damaged in many cases, as well as these circuits, which are here. So it is from underneath here where the olfactory bulb is, which is responsible for sense of smell, and here, which is the orbitofrontal region of the brain, underneath, which is like right behind the eyeball. Sorry, this is backwards for me, but here, which should be underneath here, extending back, should be here. That region of the brain extending to here, the subcortical circuits. These things, the subcortical meaning below the cortex. So up into here, these regions are what are responsible for controlling, well, for impulse control, for that impulsiveness. Remember how I mentioned that some people can act out on whatever they feel like. Well, again, whether that's gee, I want that thing and I'm just going to take it off the shelf in a store, or whether that is sexually, hey, just, have sex with any man or woman that I meet, or whether that is punching that guy over there because I don't know, I like the way he walks, whatever. It's damage to those areas of the brain which are associated with this kind of aggressive acting out and impulsiveness. Remember how I said impulsiveness and aggression go together? It's also associated loosely with interpreting intent. So you also need these same circuits to act like a mirror. And it tells you like how another person is thinking, feeling, or why they may be aggressive or impulsive towards you, or it's making those kind of predictions. And the left hemisphere does a lot of that kind of thinking as well, just as a side note. And if there's damage there, you won't be as good at doing that, and it may set you up to act aggressively or something like that. So please keep that in mind too. If your loved one is acting aggressively, they may be acting out because of damage and difficulty making interpretations. That gets into other areas, which we'll, again, be discussing later. So there are other, again, frontal regions involved in planning. Now, this area of the brain, the dorsolateral, which is here to the side, sorry, it's not high enough up, and again, but up here, this is the dorsolateral prefrontal cortex. So up here, the brown area up towards the top here. These areas are involved in planning. And some people, because they have cognitive problems, can't organize or plan something. So if you're a therapist and you're telling your patient, put your right hand on the walker, put your left hand on the walker, and I want you to get up, slide forward. Maybe you can't plan that. Maybe it's too much. And being overloaded, you act out. You're upset and confused. And that's another reason. And so if you're having cognitive or thinking problems, again, damage to those regions, and it applies to both sides, the right and the left, may lead you to act out, may lead you to being aggressive. Or if you're having problems with a video game or something like that, you may throw it because you're just so upset because you can't plan out how to play. Even something simple like checkers or chess or, just any kind of game, even, like Connect Four, whatever. Patient will throw it because it's too much, it's too taxing mentally, and they become upset. So it requires you to look into the reasons perhaps why they're reacting this way. And knowing the neuroanatomy, knowing the areas of the brain involved may help too. Okay, so they've damaged this area. Now, in some cases, they've damaged both. They've damaged both the subcortical circuits of the orbitofrontal. Remember, I said about in this region here, and they've damaged dorsolateral. Now, what's interesting, or more unfortunate than anything else, is they may want to act out. They may want to take something, grab something, whatever else, but they're not capable of forming a well-organized plan, so it'll be just impulsive violence, misdirected. And so this kind of thing does happen too. And the left side is also responsible in the dorsolateral area. Remember, dorsal fin, like think Jaws, the shark, dorsal fin on top. So dorsal describes top side. So dorso and lateral, meaning side. So top, side, here. And prefrontal is here. So that area is responsible for higher cognitive planning and executive function. But it's also responsible for things like attention and focus. And so that also plays a role. We call that dysexecutive syndrome. And again, if you can't focus, pay attention, and someone's demanding too much of your attention or you're becoming tired, another reason for acting out. So the neurophysiology, neuropathology of this plays heavily throughout. And so it's important to address this. Now, I do need to bring something up because I think it is important. The right dorsolateral frontal lobe here section on the right side is responsible for recognizing emotions in other people. So if you're trying to make sense of the world, if you're trying to, here, and you're trying to attribute to others motives, thoughts, things like that, the ability to do this partially or significantly, to be honest, comes from this area. So if again, it refers back to that kind of mirroring that I'd spoken about earlier, comes from that side as well. And so people with major frontal lobe problems, they can't figure out the motives of others. They have trouble controlling their own impulsiveness as well as the aggression. They have trouble planning, focusing and paying attention. And they're more likely to act out because they have trouble. If you remember from 3 videos ago, if you remember when I was talking about weighing the risks of behaving in a certain way, the orbitofrontal cortex helps do that too. Is if I act a certain way going to cost me more than I gain? They really can't do very well. There were a number of neuropsychological studies in the early 2000s that looked at risk-reward function, and subjects played a bunch of games with money, real money, and were asked to determine how much to bet. And orbitofrontal patients did very poorly. They bet everything they had on very uncertain hands, and when they were given sure things, they were very conservative, very, very conservative, to the point that they were defeated every time. So it's important to know the impacts of damage to these regions. Frontal lobe controls an awful lot of things when it comes to social and cognitive skills, and damage to these regions can cause a lot of difficulty, both in controlling one's own aggressive behavior and one's own cognitions, and attributing motives and behaviors to other people. So it's important to understand how this will lead to aggression. So I did want to mention the right dorsolateral frontal lobe as well. Okay, so what should you expect? What would it look like if you're dealing with a loved one who has a traumatic brain injury and they're aggressive? Well, first of all, it's reactive. Even little stimuli will set them off. So they'll become angry, hostile, even with little, something that you would be surprised at. It's like maybe someone's got a yo-yo in their hand, or is, has the TV remote instead of them, or something like that, something you go, But yes, they're extremely reactive in how they react with aggression and that kind of thing. It's typical. Again, because of everything that we just talked about. Yes. It's also non-reflective. I mean, they don't really think about it at all. Just there's no planning or organization. Again, because of those frontal circuits involved, they just do with no organization in it. And this is important too. Now, later when we talk about the instrumental type, there's a little more planning, but really not a whole lot there either. Tends to be more explosive. It just pops out for seemingly no real good reason. They may later be able to come up with a reason or something like that, but generally, they'll have to confabulate or make up a reason later. But at the moment, it just pops out. They tend to be periodic, so they will mainly be calm. And then just suddenly have episodes where they'll act out. And finally, they tend to be ego dystonic, meaning that it's opposed to what they normally are like. So they'll seek to blame somebody else for why they're acting out, or justify it, come up with an excuse. Again, relating back to what I said about the confabulation, making stuff up. So they'll try to, it's not my fault. they caused it, they're responsible, whatever. And that is consistent also with the literature. I have several books that I do use to support when I write up some of my scripts and things, and a number of the recent brain injury texts do address these kind of reactions and talk about aggression and helping to mitigate some of the effects. And they talk about this kind of way of looking at aggressive behavior and impulsiveness. And there's truth to a lot of it. I also work with brain injury patients, and I've seen this kind of thing. So I did want to address this. There are some medications and substances that can exacerbate responses. For example, alcohol is a big one. Acts on the gamma-aminobutyric acid pathways. It definitely leads to much more disinhibition. This is why we encourage patients with traumatic brain injury not to drink, because they already have a vulnerability to not only aggression, but also to disinhibition. And so we will see this made a lot worse if they drink alcohol. So definitely a big one. The benzodiazepines and the barbiturates also cause an increase in aggressiveness. Now, these drugs, you're familiar with them: Valium, Librium, and phenobarbs, and midazolam. Many of these are used to calm people down, but they can have the exact opposite effect, a paradoxical effect, in patients who have trouble with aggression. And so if you're going to use them, and many times they are used, you would need to be very cautious. So this is another group of drugs that one must be careful with. Opiates and narcotics are also drugs that put somebody at risk for increased aggression. Again, they work on different receptors. These work on the mu and kappa receptors in the brain for relieving pain. However, they also can cause this kind of aggression, disinhibition. So one has more aggression and disinhibition, actually, but they still can cause these kinds of problems. So one must exercise caution. Corticosteroids. This is kind of an interesting thing to note. Whether they're corticosteroids or anabolic steroids. We're all familiar with roid rage and that kind of thing. But yeah, steroids, just like you see often in the elderly, you'll see them become confused and aggressive. Again, that kind of disorganized stuff, but still, it can become a problem also. So just keep this one in mind. So they also can cause a problem. When you start treatment with antidepressants, this is important to note, you could see an uptick in aggression especially with some of the SSRIs or some of those that SNRIs or those that elevate the norepinephrine levels, because your energy level will come up first before mood control. And so it definitely as your energy levels go up, in those cases, you might see some of that too, some of the increased aggression. And so keep in mind this too. Stimulants also, of course. So this is another group of drugs you got to be careful with. Antipsychotics also put patients at risk. So many of the psychiatric drugs have this kind of influence, especially during the initial startup phase, or if you're making a significant adjustment or adding a second one. So it's wise for you or the psychiatrist to be careful to not mishandle this. And if they see aggression in traumatic brain injury patients, it could be one of these medications. So And you as a family member or you as a person with traumatic brain injury may want to make note, if you're having problems, if you're feeling angry, or if you're noticing that you're not exactly feeling in control. Perhaps it's one of these medications. Lastly, anticholinergics, which are used a lot of times with the elderly to help them with Alzheimer's. There's really no great treatment for Alzheimer's yet. Fingers crossed, there's stuff in the lab. But as far as like Aricept or something like that. So when we want to increase the acetylcholine levels, some of those drugs may precipitate aggression. So caution in making dose changes. And those are the primary drugs that may cause changes. Also, things like alteration in biochemistry, diabetes. When you're dealing with insulin levels, if your insulin causes your sugar to come crashing down, if your insulin levels are too high, if you have thyroid problems, this too can lead to problems like that. So it's wise to be careful about what your levels are doing. A cold or a UTI can cause changes in aggression, especially earlier on, but almost at any time. And of course, one has to watch out for the CNS infections that can cause the central nervous system infections, meningitis, encephalitis, that may be indicative. Low oxygen hypoxia can also precipitate aggressive behavior. I mean, after a while, you just pass out. However, if you're in a state of low oxygen initially, you may notice an increase in aggression. Okay, so what are we going to do about this aggression, about this aggressive behavior? There are different ways to handle it. First of all, it's important to know that not all aggression is necessarily bad. If a patient is defending themselves from a problem, maybe there's a reason for it. Maybe there's a reason they're being aggressive. But it needs investigation. You need to figure out why. Maybe there's pain. Maybe there's a problem with a person. You need to know, though. But there also need to be certain constraints. And so what we want to talk about is how you manage aggression that is inappropriate. And much of it is, at least in the early stages. And sometimes those patients with permanent frontal lobe damage or things like that, they just have trouble with social rules and understanding. And for them, it requires more advanced care, and it requires a combination of behavioral techniques combined with medications. And in some cases, there isn't too much we can do other than just apply behaviorism, and time helps some people, many people in fact. You're more likely to see these kind of behaviors with moderate to severe traumatic brain injury, although there are some patients with PCS and with persistent concussive syndrome, who may have a mild traumatic brain injury. As we've learned, really, there's no such thing as a mild traumatic brain injury. So, all right, first of all, we'll divide them into more of the organic brain syndromes and talk about that, and then look at things we can do for that instrumental kind of violence where a person's got a plan or an idea and they are trying to carry out something for personal goals and using aggression and violence to get it. But that's definitely more on the psych side as opposed to the psychiatric side, more on the psychologist side versus psychiatric. So there are a couple different choices when you're dealing with disinhibition. One of the things you may want to use for a case of disinhibition is amantadine, which is commonly used most often for for pseudobulbar affect, which is like uncontrollable crying, or for uncontrolled laughing or whatever, and where it's not congruent with how the patient actually feels. It's more of a discontrol. But we found in research that it does help with the cognitive, improve some of the cognitive and awareness kind of things. So amantadine may be given, to help. Also, the psychostimulants. These kind of things are the Adderalls and the ADD, ADHD kind of medications. Again, to help kind of light up those areas in the frontal lobe, the dorsolateral areas, to help the patient focus. And we spoke about the dorsolateral regions, to help kind of light these areas up and to get the patient able to pay more attention, to focus more. It may be an application eventually for nootropics. There's not a whole lot of research on this, but cognition-enhancing medications. So that is perhaps a possibility. That would be an area for research, ongoing research. There are things in the lab currently, but I'm not talking about the kind you think about when they're talking about students trying to use other stimulants to help them think. I'm talking about things in the lab right now. Also, atypical antipsychotics can be used to help control impulses. They would typically be combined with SSRIs, which seem to be best for disinhibited traumatic brain injury patients. So what you're dealing with here are things like Prozac and Paxil, and, those kind of drugs are what you're interested in. Also, you have other things that you can use to help as well. You can use the anticonvulsants, which are common, valproic acid, excuse me, lamotrigine, Lamictal, or carbamazepine, which are the ones most commonly used to help with like mania and that kind of thing, overexcitation. What's important to remember is just because they say it's for a specific psychiatric disorder, not necessarily. They can be used what's called off-label, which is for purposes other than for which the FDA has approved it. A lot of psychiatrists or doctors in general do this with medication because it really focuses and targets specific neurotransmitters in specific areas of the brain as opposed to being specifically for a disease. Just so, so you're aware. Lastly, again, for this kind of impulsiveness, is the use of anti-androgens. They inhibit testosterone and the male hormones. And we found that it's not just with males, but also with females. If they are disinhibited, it may be something to help control drives that they're having problems with. So these are things we can administer, different medications that we use for problems with disinhibition, aggression, kind of together whenever we see them together causing a problem. For acute aggression, we tend to use, for short-term only, and this is important, we do tend to use the antipsychotics, and for those kind of responses we use also the benzodiazepines. Now, if you remember, I said they can bring on the very aggression. So it's important to understand for how long we'll be using it, not for more than a few weeks. And to be monitoring the doses. If you have a loved one who's on this, you need to ask and make sure you note how long they're going to be. Is there a plan to taper them off, and what to do in case their condition gets worse as far as aggression? Because it's not really intended to be used for long term. And so it's wise that there be a solid plan made for what it's being used for and how long. So these are the two primary classes of medications. The antipsychotics typically used includes aripiprazole, quetiapine, olanzapine, those kind of drugs. They're fairly benign. They don't have a lot of side effects. Sure, they have some, but every medication has some. But the good news is these are fairly directed. They're aimed at specific dopamine subtypes, and so we know that they have a good profile and they won't really make a patient worse generally. The reason I say generally is because, again, we try to avoid antipsychotics in patients that are having a problem with their aggression because it can make it worse. But these have been proven through studies to have the least likely to make a patient more aggressive or to have other symptoms. So these are your better choices if you're going to be using it strictly to manage aggression or disinhibition, that kind of a thing. If these second generation, these newer antipsychotics prove ineffective, it may be necessary to switch to a low dose of haloperidol. And in cases where the patient is a direct threat to themselves, others, because of aggression, this definitely is a reasonable option. Of course, you have to monitor them for EPS, extrapyramidal symptoms, pseudoparkinsonism, and so it's important and it's a higher risk to use it. But again, you have to weigh cost versus benefit. And it's important. And in some cases, yes, indeed, they may be at higher risk for injuring themselves again or causing major injury to somebody else. And so, yeah, there are times when haloperidol is absolutely called for. Also, the benzodiazepines. Not something we want to grab for right away, but certainly another option. Librium is possibly a choice because it's short-acting. It processes through the system, and if there's a problem, obviously allow it to metabolize more quickly. This is another option. So you'd be wanting to look for anything that's short-acting, any of the benzos that are more short-acting, because you don't want this hanging on for hours and hours, especially if they have an aggressive reaction. So that would be your probably your best benzodiazepine, and that's something you want to ask whether it's appropriate or not. Now, there are some patients for whom long-term treatment is necessary. And those patients require many of the same medications, but a differing dosage and a combined strategy because there may be other factors at work. There may be psychiatric disorders underlying them, which may be due to the traumatic brain injury, but you're looking to treat other factors such as chronic depression or anxiety. And even the patient may not be aware of these. So you're looking to treat the underlying cause as well as the cause of the aggression itself. So what the treatments will be, as I said, will be similar, although there are some other options which I'm going to include too. So you're going to be asking, first of all, is this aggression a deviation from the way they would normally act or acted before their injury? Again, hesitate to use the word normal, but in other words, was this person always kind of aggressive or mean before? Were they not a very nice person to begin with? Unfortunately, if that is the case, then all the treatment in the world isn't going to fix that. If they already were kind of a jerk, sorry, but that's just the truth, they're going to remain kind of a jerk. A brain injury is not going to improve your disposition as far as that kind of thing is concerned. So, if that's baseline for them, we're going to have to rely on more behavioral techniques and things for family to do for themselves. But if this is new, if Pop was always a little, kind of mean to the kids on the lawn, or, something like that, or spoke his mind a little too freely at Thanksgiving before the injury, this is likely to be a problem. And again, it will require familial intervention for that, and at a more behavioristic kind of level, reinforcers or punishers or things like that you could do. If, on the other hand, this is Aunt Mabel, who's always been really nice to everyone, very kind, supportive, helpful, that kind of thing, then you probably can make more of an effect with pharmacological intervention and over time, as neuroplasticity applies here and those areas of the brain rewire. There likely will still be some lasting effects, but there are things you can do. Naltrexone is, most people think of it as for addiction. It's not. It works on a separate pathway from many of these other drugs, but it definitely can help with aggressive outbursts, irritability, that kind of thing. It's good for chronic or long-term aggression. Again, usually this kind of aggression is not focused or organized. It's just it's helpful for patients who have other psychiatric problems. Again, this is more an adjutant or an adjunctive agent. It's not used as a first line typically, but it may be used with other agents. Although there are some cases where it's used exclusively, but that's pretty unusual, only if you're having difficulty using others to help. Sertraline, escitalopram, citalopram, those are the most commonly used SSRIs for treating chronic aggression, because serotonin is one of those mood modulators. Again, keeping in mind that this patient may have pre-existent psychiatric disorders. So if they have chronic depression, you want to aim to try to bring the levels of serotonin and norepinephrine up, and in order to help them treat that underlying cause. Many patients who have traumatic brain injury have a history of psychiatric disorders before. In fact, that is one of the risk factors for traumatic brain injury, is that having a psychiatric disorder for a variety of reasons, including more likely to be impulsive or more likely to be in an altered state at some point due to various mental health issues. It does have a clinically significant impact on likelihood of traumatic brain injury. It's kind of an interesting but important fact to note. And traumatic brain injury will exacerbate any pre-existent mental health disorders. So if a person has symptoms from their mental health disorder, depression, anxiety, whatever it may be, manic depressive disorder, expect to see them become far more severe. And so if you treat that disorder, you will be able to help treat aggression or acting out. So it's important to address this. And of course, the same systems are involved, but they also many times will face problems like disinhibition, or they will face that aggression due to some of the cognitive deficits, or due to problems with planning, or due to problems with that type of risk assessment of doing this won't be as risky for me, and yet ultimately then they end up paying a consequence for it. So just keeping that in mind. So saying it's important, if a person has a mental health problem and they suffered a traumatic brain injury, that needs to be treated and monitored even more closely. So just a heads up for family and caregivers, as well as patients themselves. SSRIs are typically also recommended for cases where you see like pathological laughing, crying situations where it's extreme and out of control. But you have to differentiate between that and pseudobulbar affect. So the question for which would be merited amantadine. So you need to find out if the patient's mood matches their mental, their how they're feeling. In other words, if you're crying a lot, are you sad? Are you depressed? Or are you kind of neutral or don't really care, but you're crying a lot? Are you happy, sad, and does it match what your face is doing, how you're feeling? And so all of this affects, because that's the difference between what you get. And family members, again, this is important to be advised because you want to make sure your loved one is getting the right treatment. You don't want them spiraling into a depression and they're getting amantadine because someone thought, oh, it's pseudobulbar affect, non-matching mood to response, when actually they're very depressed and they're on the way down. Also, things like lithium are an option, but that's mainly directed for manic depressive disorder. So again, and that requires close monitoring of the blood. So that's one of those drugs where it's meant for what it's meant for. And that's one you don't reach for typically right away. You'll be looking for a lot of the anticonvulsants to induce stability in the brain, to cause the brain to be electrically more stable. If somebody's acting out because of anxiety, if they're being aggressive over an anxiety-based problem, that requires a different approach. Buspar is a good one. It's gentle, and now it takes longer. It works on the serotonin receptors again, but it's an agonistic medication, and so it will, again, it kind of works in that way, sort of like the antidepressants, but its targeting is different. It's looking for a different serotonin receptor, and it will try and, over time, bring down levels of anxiety. Again, serotonin being a mood modulator, kind of like the thermostat, to help reduce anxiety, and TBI patients are more tolerant of it, and so to help reduce their anxiety. And patients who are anxious can also be physically aggressive, trying to reduce that source of anxiety. One thing I do want to throw in there, just reflecting, it's important to note that patients who are taking lithium with brain injury are definitely more susceptible to toxicity, specifically neurotoxicity, but general toxicity as well. So they need more frequent labs. So just as a note, but general toxicity as well as neurotoxicity. So, because, well, lithium is a salt, and there are a number of proposed different reasons why it works. One of which is that it does not stay outside of the sodium channels as long because it's smaller and it falls back into the cell more quickly. It's at least one of the theories. We discussed how the sodium channels work on the neuron video. And so you may be interested there. Just in your mind, substitute lithium for sodium. And because lithium is much smaller in physical size, it precipitates back more quickly. At least that was one of the theories behind how it works. There are many medications for which we don't actually completely know how they work, but we have theories. And so just a little tidbit there. Finally, one of the last reach fors in these kind of cases is beta blockers. It seems to work fairly well, actually, but because of its other physiological effects, beta blockers like propranolol, metoprolol, those kind of things, they are an option for patients with generalized aggression. It kind of stops a feedback loop. But these are an option also. They interfere with beta adrenergic cycle, and they will prevent that kind of feedback that a patient finds with aggression. And it's kind of like telling the brain, hey, you don't need to be angry. You don't need to be aggressive. I want to touch on something that's hyper controversial and really, 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 really rare. I think I know of like 3 cases or 4 cases. There may be more than that. There is a procedure called a stereotactic bilateral amygdalectomy or amygdalotomy, depending on what the procedure is exactly done. This is incredibly rare. I don't want you to think, oh my God, there, like I said, 3 or 4 cases that I know of. Here in the brain is the amygdala, right down here, my thumb is. That area of the brain is responsible for fear and aggression. Not exclusively. I mean, it's far more complicated than that. There are a lot more networks involved, but that center controls fear and aggression response. If you were to, say, remove that center of the brain surgically, you would have a person who has neither fear nor rage or anger. Again, it's more complicated. It's always more complicated than that. However, there have been some incredibly rare cases where they've removed this part of the brain and the patient was more docile. No, it's not a lobotomy. That's not what a frontal lobotomy is. That's something else. That is a horrendous procedure of 100 years ago. But the stereotactic, the bilateral stereotactic amygdalotomy or amygdalectomy, which is the removal of, is something that's been done in some very rare cases for a person whose aggression and rage out of control. And so those were done mostly in unusual cases of herpes encephalitis and things like that, where a person just had no self-control at all. But I just wanted to, for the sake of completeness, mention it here. Now, finally, I want to talk about instrumental aggression. What this is a situation where, especially with like mild brain injury patients or patients who are far enough along where they use aggression to try to control other people's behavior, where there's kind of a plan, but usually it's not a very good one. And in those cases, it's because often you've accidentally reinforced bad behavior in the patient. This is kind of like the 3-year-old who knows that throwing a tantrum will get them a toy. Well, in some brain injury patients, they've gotten rewarded for acting out. And so it requires a psychiatric or a psychological technique. Behaviorism. Skinner, we all remember him. So what you're trying to do here is you're trying to find out what happens before, antecedents, ABC. You're trying to figure out what's going on here. So first of all, what are the conditions set before? By the way, this applies to other forms of aggression too. What's going on first? Then what is the behavior exactly? And you want to describe this. There are a lot of scales and things like that, and a lot of sheets of paper and a lot of like systems. You can find them on Google. All right, so antecedents, what comes before, the behavior, describe it. Not like, I think they're thinking this or what. Literally write down what they do. Do they bite somebody on the hand? Do they spit? Do they throw something? Do they cuss a lot? Do they, or do they scream, yell, do they, whatever. Write it down. And finally, consequences, are there any consequences? What's the outcome? And that will give you a chance to see what's going on first, how they act. Is somebody certain present? Maybe it's anybody. It'll allow you to analyze, systematically taking notes, what's going on with this type of behavior. And then what you do with that is you're going to try to see, hey, can we alter, being a little scientific here, can we alter something in the beginning? One of the antecedents, can we change something? maybe you can't. Then maybe you've got to alter the consequences. Maybe they're getting away with it. Maybe, hitting mum gets them attention from somebody they like. Or maybe it gets them, as I said, out of some activity they don't like. And so perhaps they then need time away, just like time out. Yep, that's one of the things. Or maybe whatever's rewarding them, whatever it is they're getting, needs to actually be removed every time they do that. And it needs to be explained what the consequences are, whether they really get it or not. You need to be clear about what's going on. Although in some cases, especially if it's if they're fairly limited with their awareness, this really may not reach them at this level. But you have to all, and I mean all, be on the same page if you're going to use a behavioral technique to try to change a behavior. You can't have one outlier. Everybody, and I mean everybody, has to agree to abide by the rules. Everybody, if you're going to make the change. What's important to understand is a lot of these social, emotional, psychiatric skills were learned at one point. Whether it's empathy or whether it's whatever, whether it's aggression or not acting aggressively, they all were learned, and they can be learned again. But it requires consistency, and it requires valuing what it is that is being taught. So this kind of thing, like helping avoid instrumental aggression, helping deal with it, requires that kind of consistency and valuing what it is about. And so I want to stress that, yes, there are ways to handle aggression, but you have to be, especially if you're using a behavioral technique, which unfortunately cognitive techniques don't work as well, especially with moderate or very much so with severe brain injured patients. You have to be more classically Skinnerian. You've got to have rewards and punishers. And I'm not talking about hit someone. No, never, never, never. I'm talking about taking away things that are rewarding or giving them something that they like in exchange for behaving in an appropriate way. So if you catch them doing the right thing, they get rewarding for it. And you may say, well, that's kind of treating them like a kid. Yes, unfortunately, because they have to relearn that skill. Just like every other element of rehabilitation, they have to relearn. And you have to use the same techniques you do for a kid. It's not belittling. It's not insulting. It's what's necessary to help them be able to reintegrate successfully. They need to be taught these skills. So it's a matter of going through. And it doesn't matter, about it's not about treating them like they're a child or anything like that. It is about enabling them to be able to function socially and in society again. And patients have problems with excessive aggression or with disinhibition or any of those kind of skills have to be retaught. And unfortunately, a lot of doctors, nurses, and people who don't specialize don't know how. They were never taught about patients with traumatic brain injury. And so it requires a special set of skills for it. So this is my section here on aggression, and we addressed a little bit of disinhibition too. So thank you, and please like and subscribe to the channel. Detours, Understanding Acquired Brain Injury, and see you next time. Bye.